Systemic lupus erythematosus is an autoimmune rheumatic disease of unclear etiology characterized by autoantibody production and extremely variable organ system manifestations. Age at onset is variable. 65% of patients with lupus have disease onset between the ages of 16 and 55. Of the remaining cases, 20% present before age 16 and 15% after age 55. The etiology of systemic lupus erythematosus remains unknown. It is clearly multifactorial, which might interact to cause lupus, which includes environmental factors, hormonal factors like being female, and genetic factors. In a genetically predisposed individual, various environmental and hormonal triggers can establish a state of immune activation. In lupus, a dysfunctional immune system can manifest years before the onset of clinical symptoms with the presence of autoantibodies and enhanced immune response in preclinical stages. This interplay will lead to clinical features and organ damages like atherosclerosis, coronary heart diseases, infections, cancer, and renal failure. Lupus has many different clinical manifestations, which we will discuss in this video, like arthritis, pericarditis, skin rash, pleuritis, vasculitis, neuropsychiatric diseases, and a lot of others. Mucocutaneous lesions can be as acute, subacute, and chronic lesions. One of the acute rashes include malar rash. The classic lupus butterfly rash presents acutely as an erythematous, elevated lesion, pruritic, or painful, in a malar distribution, commonly precipitated by exposure to sunlight. The rash may last from days to weeks and is commonly accompanied by other inflammatory manifestations of the disease. Another acute skin rash of lupus is acute cutaneous lupus erythematosus. These lesions are abrupt in onset, frequently appear after exposure to the sun, and are characterized by erythema and edema. Subacute cutaneous lupus lesions' typical features include symmetric, widespread, superficial, and non-scarring lesions. Involvement of the neck, shoulders, upper chest, upper back, and extensor surface of the hand is common. One of the chronic rashes of lupus is discoid rash. Facial discoid lupus rash with a malar distribution. Discoid lesions are usually found on the face, scalp, ears, or neck. Alopecia can be due to lupus. Alopecia is an exaggerated hair loss which occurs in most SLE patients. It may involve the scalp, eyebrows, eyelashes, beard, and body hair. Scarring alopecia is a complication of discoid lupus that typically affects the scalp. Lupus hair is characterized by thin hair that easily fractures. It usually occurs along the frontal hairline, is associated with disease activity, and grows back normally as the disease subsides. Involvement of the mucous membranes occur in 25 to 45% of SLE patients. The most common manifestations include irregularly shaped raised white plaques, areas of erythema, silvery white scarred lesions, and ulcers with surrounding erythema on the soft or hard palate or buccal mucosa. Oral lesions may be the first signs of lupus. Involvement of the upper airway mucosa can also occur and cause hoarseness. Joint involvement is classically described as non-erosive, non-deforming arthritis in a distribution similar to that of rheumatoid arthritis, primarily affecting the small joints of the hands, wrists, and knees. Arthritis may be the presenting symptom or accompany other lupus manifestations during a flare. Myositis, which is inflammation of the muscle, is characterized by myalgia, and muscle tenderness are common during disease exacerbations. Inflammatory myositis involving the proximal muscles has been reported in 5 to 11% of cases and may develop at any time during the course of the disease. Renal involvement occurs in 40 to 70% of all SLE patients and is a major cause of morbidity and hospital admissions. Immune complex formation, deposition in the kidney results in intraglomerular inflammation with recruitment of leukocytes and activation and proliferation of resident renal cells. Urinalysis is the most important and effective method to detect and monitor disease renal activity. SLE affects both the central nervous system and the peripheral nervous system. It is the least understood manifestation of the disease and remains a complex diagnostic entity as a result of its multiple clinical presentations. The clinical features are collectively referred as neuropsychiatric SLE syndromes. Generalized and focal seizures are reported in 7 to 10% of patients and may occur either in the setting of active generalized multisystem lupus or as isolated neurologic events. Seizures are also associated with the presence of antiphospholipid antibodies. Demyelination, transverse myelopathy, and chorea are rare manifestations occurring in less than 1% of patients. Clinical and neuroimaging evidence of demyelination may be indistinguishable from multiple sclerosis. Up to 8% of SLE patients develop inflammation of the retinal artery during the course of their disease. An equal number of patients have infarction of the retinal vasculature secondary to antiphospholipid antibodies. Retinal vasculitis is usually associated with generalized active systemic disease and presents early in the disease process. Corneal and conjunctiva involvement is usually part of Sjogren's syndrome associated with SLE. Uveitis and scleritis are extremely rare manifestations in SLE seen in less than 1% of patients. Optic neuritis is rare and may be associated with transverse myelitis. There are many cardiovascular features of SLE. Pericarditis may occur in approximately 25% of SLE patients. Pericardial effusions may be asymptomatic and are usually mild to moderate. Tamponade is rare. Myocardial involvement is rare and typically occurs in the presence of generalized lupus activity. The most common pleuropulmonary manifestation of SLE is pleuritis. Pleuritic pain is present in 45 to 60% of patients and may occur with or without a pleural effusion, with clinically apparent pleural effusions reported in up to 50%. Effusions are usually bilateral and equally distributed between the left and right hemithoraxes. The effusion is invariably exudative with higher glucose and lower lactate dehydrogenase levels than those found in rheumatoid arthritis. Hematologic abnormalities are common and can be the presenting symptom or sign in SLE. Major clinical manifestations include anemia, leukopenia, thrombocytopenia, and the antiphospholipid syndrome. Gastrointestinal manifestations are reported in 25 to 40% of patients with SLE and represent either lupus involvement or effects of medications. Dyspepsia has been reported in 11 to 50%. Peptic ulcers, usually gastric, in 4 to 21%. Abdominal pain accompanied by nausea and vomiting occurs in up to 30% of SLE patients, and they could also develop lupus hepatitis.